and harm reduction workshop. We are going to, as people trickle in, if you could introduce yourself in the chat with your name, agency, role, and pronouns. And if you have a chance, if you could check your directory listing and make sure we have you in there. And if we do, it's correct and updated. And also if you provide free naloxone, needles, condoms, or fentanyl test strips, let us know. We'll add that into the directory so people can search for you and find it. And then we have a couple of links to our handouts and our safety plan template. And just so you know, we will be recording just the panel part and the safety plan part, not the breakouts or the chat. So hopefully you'll feel comfortable sharing those spaces. Thank you, everybody. Thanks for joining us.
Don't pop like trouble breaking into your heart like that. Cool shakes on the hair, owe it all to my mother. Hot like summer, yeah, I'm making you sweat like that. Break it down. Oh, when I look in the mirror, I'm not too hard to do. I got the superstar glow, so to the booty. A side step where I love to love me. I let the moon rock with me, baby. Know that I got that heat. Let me show you just how you see it. Side step where I love to love me. Get it, let it roll. So smooth like the car I ride. Even your best party planner couldn't catch this vibe. Big boss and I make a hater stay on their job. And I be on these girls' necks like the back of their bobs. Houston's finest in the room with bouncers. Make them all get budget in their suits and blouses. I remember writing flows in my room in college. Now I need global entry to the shows I'm rocking. Smooth like cocoa butter. My drink more than a puddle.
All right, I think we have a good amount of folks here. Get going.
Great. Welcome, everybody. Thank you so much for joining us this morning for our workshop on substance use overdose and safety plans. We're super excited to share this with you with this awesome panel of experts. If you're just joining us, please introduce yourself in the chat with your name, organization, and pronouns. And we will get started with a healing practice from Ramon Jackson, who is a member of our East Bay Advisory Board and also just leads beautiful healing practices. So just really an honor and privilege to have Ramon join us and do that for us.
Good morning, everyone.
Good morning.
If we could take a deep breath and close our eyes, centering yourself, planting your feet firmly on the ground. Today, we speak gratitude into the universe and into ourselves. Taking a deep breath. You can say these things along, or you can say them in your head. Taking another deep breath. Today, I am grateful for the time I have been given to do the excellence in the world that I have been appointed to give. Today, I speak gratitude for everything good I have done, for the extra time I have been given to do more good, to change, to lift, to empower. Today, I am grateful for everything that I have, for everything that I am, for everything that I bring. Breathing in deeply. Speaking gratitude for every experience, good or bad, that lends to the excellence that we give from ourselves. Breathing deeply. We want to speak gratitude and thankfulness for being present, for being open, for being malleable and expansive, for just sharing and for caring. Breathing deeply. We speak gratitude for being, allowing. We speak gratitude for peace, speak gratitude for joy. We speak gratitude for community, for our small villages and our large villages that support us in doing the work that we do. We speak gratitude for the universe, positioning us in this space, in this time. Taking a final deep breath, exhaling out all negativity. We speak gratitude for this space, for everyone present, for everyone participating, for everyone sharing. Ashe.
Ashe.
Thank you. Thank you, Ramon, for that deep practice, that beautiful practice, and for grounding ourselves in gratitude and presence with ourselves and each other. Thank you so much to all of you for joining us today. I am going to give you a little bit of a background here as we get started on what we're here to talk about together. So this is our workshop on substance use overdose prevention and safety plans. And our intentions today are to increase collaboration between those of us working in HIV and substance use. And I think some of us have also joined from Healthcare for the Homeless as well in the East Bay. We want to share stories and experiences with each other on substance use overdose prevention and the use of safety plans. And together, we're going to practice writing an effective overdose prevention safety plan. We've gone through our introductions and Ramon's awesome and excellent healing practice. We're doing a background right now, and then Sean Demmons is going to lead us on a networking activity and breakout session, which will not be recorded, so you guys know that. So you're comfortable sharing and speaking. And then also we'll have an awesome panel on harm reduction with Dr. Eric Anderson, Bronze Courtney, and Kate O'Brien. Bronze is going to lead us on a demonstration on how to use naloxone, and Kate will show us an example of a drug log, which was a predecessor of the safety plan template, which we'll share with you as well. We're really excited to share with you a safety plan toolkit today, walk through that, and also practice cases with you. This is one of our East Bay HIV strategic priorities for this year. As you can see here under improving collaborations, our goal here is to build capacity and collaborations on substance use overdose prevention and safety plans. So thanks so much for really joining us to do this. This is a priority that our community members have named over the past year as a big, crucial priority. And this is one of the reasons for it. So as many of you know, in our community, on your personal and also professional experience, overdoses have been increasing over the last few years. So both fatal and non-fatal overdoses of all different kinds have been increasing. This is the graph for Alameda County broken down by race and ethnicity. And you can see also disproportionate impact on our Black and African-American residents here in the orange line. This is also the case for Contra Costa County. So in the orange line here again, and also just overall rises in overdose deaths and disproportionate impact on our Black and African-American residents. In addition to that, drug overdoses are the leading cause of death for people experiencing homelessness, as shown in the Alameda County homeless mortality report that just got released last week. And for people experiencing homelessness, overdose deaths are 43 times the rate of the general population. So really huge disproportionate impact on people experiencing homelessness. There's also overlap with HIV services. So while overdose deaths have been increasing, HIV testing has decreased. So we have a lot of catch up to do from this pandemic. In addition, we found out during the pandemic that among the people not linked to HIV care from the Highland Emergency Department in 2020, 86% had a substance use disorder. And people living with HIV who inject drugs are also less likely to be retained in care or virally suppressed in our HIV access analysis. So disproportionate impact in terms of HIV engagement and care for people who use substances. But we also know what works. So we know that medications for opioid use disorder decreases HIV transmission. And we also know that treatment for substance use improves our HIV outcomes. So there's a lot of overlap here, and this is why we want to talk about this all together in a holistic way. So with that background, I want to transition this over to Sean Demmons from the AATC, who's going to lead us in a breakout session and on a networking activity. Take it away, Sean.
All right, thank you, Sophie. Hi, everybody. And again, welcome to this East Bay Linkage and Retention workshop. So, we are not in person. We're still mostly virtual, so we don't get those opportunities to connect with each other. And so I put this together to give us, a chance to talk with each other, check in, see how things are going. And I've created these 3 questions that I want folks to respond to in your breakout groups. So in a moment, Jessica is going to set up some breakouts, and you're going to respond to these 3 questions after you've introduced yourself to each other. So you'll share again in your small group your name, organization, and role. And then I thought it would be good for folks to talk about org updates, because a lot of things have been happening, behind the scenes during the pandemic. Are we open? Are we closed? How are services being delivered? Share that with the folks in your group. And also any resources that you may have that you want to share related to this topic, or just the work in general that we do. And in org updates, you can include like staff changes, anything different going on in your organization. And then, bring a little levity to the chat you'll have with each other. Share with each other, what's your secret talent that no one knows about? What do you do that no one knows about? And then lastly, I hope you'll spend the bulk of the time. You'll have about, I think it's 8 or 9 minutes in this breakout. And want you to talk with each other about what really inspires you to use harm reduction, especially when we're working with folks that just aren't ready for treatment and that are ready to, they really kind of want to continue to use. What inspires you around that? And then, actually, let me back up. When you get there, you pick who's going to come back, because we're going to come back out to the larger group. And we really want to hear, the responses. Whoever's your note taker and your person that report backs, really glean from the discussion some of the highlights, and we'll have an opportunity to share that out to the larger group. So what I'm going to do right now is I'm going to share in the chat the questions as Jessica gets ready to send you all to a breakout. And then you'll have them in your breakout in case you forgot them and you won't have the slide in front of you. So there they are, they're in the chat. And so Jessica, you can go ahead and let them go to breakout.
Okay, great. Here you go.
All right, thanks.
Thank you so much, Sean. And it's just great to be in these groups. We had such a multidisciplinary group too. Like we had legal folks, harm reduction folks, direct service, street outreach folks. So it's just great to have a wonderful, diverse group like you guys. And just awesome to see your secret talents too. Not so secret anymore. But anyway, so thanks so much for coming back to the large group and sharing. We are now going to transition to a panel. So Jessica is going to help spotlight our folks here, and I'll just tell you a little bit of background on this panel and what we're aiming to do. So this is a panel on real life harm reduction and overdose prevention experiences. The goals for this panel are to share stories and lived experience around supporting clients and each other on strategies to keep people safer when they continue to use. We will discuss how to engage people in harm reduction, use naloxone for overdoses, use drug logs and safety plans to lower the risk of overdose. We have a superstar lineup of panelists with lots of experience in the field and in diverse settings. We have Kate O'Brien, Outreach Coordinator with Punks with Lunch. Kate presented at our substance use workshop in October, which some of you were at, and we learned so much from her insight, her experience, and her ways of making harm reduction realistic and very person-centered. And it was Kate's brilliant idea to create a safety plan template, which we now have, and we are so excited to share it with you. We also have Bronze Courtney, Executive Director of HEPAC. As many of you know, Bronze is a linkage OG, and Bronze got us started 11 years ago on our first big collaborative project on interagency warm handoffs, which has now become our standard of care. So thank you, Bronze, for that. Bronze continues to inspire us with his leadership and on-the-ground perspective, and his positivity and his dance moves keep us motivated and going.
Hit him with the shoulders.
That's right. Dr. Eric Anderson is the Associate Research Director at and attending at for the Substance Use Disorder Program at Bridge Clinic at Alameda Health System. Eric has been a longtime collaborator in our HIV and emergency department initiatives at Highland, which has been so great and just like has strengthened so much over the last many years. He's also been an awesome champion of harm reduction in clinical settings, where it's so super important that we meet people where they're at. So really big, let's give a warm welcome to our panelists and let's dive in. Feel free to type your questions and feedback in the chat. Sean and other folks will help look at the chat and answer your questions and also unmute when we need to discuss in real time. So with that, welcome to panelists. And I'm just gonna get us started with some questions to link us to what I shared earlier around the background of the rise in overdoses here. So question for the panelists: what has happened over the last few years that have contributed, in your opinion, to these rise in overdose rates? So if anybody wants to jump in.
Well, it's the elephant in the room, and it's called fentanyl, and it is a mess. It's sad that this is hitting us not just locally but nationally. We're hearing about fentanyl related overdose deaths in every part of the United States right now, specifically in urban Black and Brown communities, which is impacting, I don't want to say more so, it's impacting a lot of communities, but specifically in Alameda County, Black and Brown folks kind of have the highest rate of overdose as it relates to, fentanyl. And it's so interesting because fentanyl is in everything. And we were having conversations around people who, one, are seeking fentanyl because they're like, oh, well, I know how to use it and I'm not gonna be one of those ones. And then you have folks who are seeking some other sort of drug, right? People who want stimulants and are not even looking for any kind of opioid drug, and fentanyl's inside of there and they're overdosing. They're like, hey, I thought I was getting coke and there's fentanyl in there. Why would somebody put fentanyl in cocaine, right? And so we don't know why. We all have our reasons, obviously money related, economics as it relates to drugs and the purchase and the sales of drugs, but fentanyl is killing us out here. And so, as you will probably hear, a lot of us have personal stories that has impacted a lot of us and still impacting us today. So that damn fentanyl is like, we need to get a rein on it.
Thank you, Bronze. Yeah. Kate and Eric, anything you want to add to that?
I totally agree with you, Bronze. I was just going to say safer supply. Our drug supply is just completely a disaster.
Yeah, we're seeing more and more overdoses at the hospital too. And I totally agree with Kate and Bronze. Like it's hard for people to know what they're using a lot, right? And it's fentanyl's in everything. That's what you say. But it's like, how much and were you expecting it or not? And it can be really, really difficult. And it's harder to, it's certainly harder in every way. And the other thing I'll just add is like COVID, right? Like it's been an awful couple of years and more isolation and people are not as connected as before. And I think that's also contributed, right? And I think we see that in, some of the data that Sophie presented earlier. It's just like things are getting worse. Fentanyl, meth, and COVID has just been a kind of a bad storm.
What's interesting is I get these like updates. I don't know if you guys can see this, but fentanyl was seized, right? All this was seized, but you think that would stop it or lower it, but this is a drop in the bucket. And then there's been like some documentaries. I've just been so like involved in like learning about fentanyl and where it's coming from and like the whole process. And there's just so many documentaries out there of like where they're following the fentanyl from the cartels and even before the cartels, the chemists who are making the fentanyl up and how it's getting through the border to the fact where it hits the street. And it's just, when I hear, oh, there's a seize, I'm like, that's great, but there's still a problem out here. So, as the rest of our panelists, it's like, you just got to normalize the conversation around fentanyls and everything. And we need Narcan on everybody, like you would have your keys and everything else. So I would love there to be more seizures of fentanyl so that we can get more of it off the streets. But this is just the world that we're living in right now.
The one thing I'll add to it, I see a comment in the chats about, treating withdrawals harder, getting patients on medications for AUD is harder too. And I think that is true for some people, but I also think that there's probably some reluctance in the community about fear of getting people on medications for AUD if they're using fentanyl. And while it is everywhere, like we can start meds for folks who are using fentanyl. Like it's possible. It might be harder for some people, but we've gotten creative with how we're doing that. And we'll hear about that with some of, I think what Kate's going to talk about later too, but like we can get creative with medications and it's not like, it's not an impossible task to try and really engage meaningfully with people.
I would also love to see more access to mass spectrometers, like for regular people. And for those of you that might not know what that is, it's like a fancy drug testing machine. But I would love for people to have a place where they could just walk in off the street and get their drugs tested without fear of any repercussions around that. I would totally use that personally.
Yeah, and
So-
Kate, just so for people who don't know what a mass spectrometer is, it basically identifies the different components of a drug. Is that right? It'll tell you like how much of what.
All
is
this
in there.
stuff.
Yeah.
Yeah, all the stuff.
Yeah.
that's in
And
there.
it's far more accurate than a fentanyl test strip, for example.
Yeah, because it's also not just, I mean, obviously fentanyl is a huge part of this, but it's also like lots of the drugs have a bunch of stuff in there that you wouldn't expect to be seeing.
Mhm. And it's interesting because, yeah, with the fentanyl test strips, it just lets you know that there's the presence of fentanyl, right? And nothing else, right? And then, but how much fentanyl is there? You'll never know. But those machines are not cheap. So it would be great if everybody on this line got together and advocated to public health that, places like Punks with Lunch, places like the Bridge Clinic, people can come in there and literally be like, here, can you test this? Where they can go to a syringe service program out on the street and not fear like, oh, I'm going to get caught with possession of drugs. I'm sitting here trying to test my drugs. My goal would be, hey, let's have these at the concerts where we know people are like drinking, partying, carrying on. It's like, hey, I got some dope here. Can you test it and let me know? So then you know how to move as careful as possible, because in harm reduction, it's not what you do, it's how you do it. We're not saying stop, we're not saying do it, but if you are going to know what you're getting and then have the tools to do it as safely as possible.
Yeah, that's perfect. Oh, sorry, Kate.
Like,
One
one
last
last
thing, and then
thing.
I'll ask the next question. Yeah, go ahead.
It would also theoretically allow us to impact like the drug supply. If we had kind of a map of where the worst drugs were and where the better drugs were, people would automatically go towards better drugs, and that would make like people that bring drugs in have to up their game.
Yeah.
Oh, like a Yelp for for drug dealers.
Literally,
Yeah, that's a great idea. It's great. Yeah, crowdsource that intel, right? So this is a great connector. There's this like big picture policy thing and tools that we need to get a hold of and give people access to. And then there's also the interpersonal piece, right? So how do we engage people in harm reduction? Like what's your opening? If you find out that somebody's using, how do you engage people in that conversation?
I like to just ask, how's it going, first of all, with just you as an individual person? And if you're coming to the exchange and you're an identified person who uses drugs, it's like, so how's the drugs? Just have an open dialogue. Like, how's your coffee? How's your drugs going? Like, what is great about it and what's not so great about it? And then we start having the conversation around opioid overdose, which always comes up with substance users, right? Because it's very prevalent for people who use drugs. So it kind of gears us into that conversation for people to have open dialogue around like, oh, I love this drug. I have a great dealer. I can trust him. The drugs are clean. I don't get a lot of abscesses. We haven't experienced overdoses. And then you got people who are like, the dope is crap. I've had to save 2 or 3 people in this part of town. And it's like, y'all are the field experts. People who use drugs are field experts. We need to hear from them, like what's good, what's great, what sucks, what you love, and how as we as an agency can support you in that. Because we're not telling you to stop. We're saying, hey, we got all the tools for you to do your shit, as clean and safe as possible.
I would just piggyback onto that, that I basically just start off with anybody I work with, trying to develop rapport and build trust with them and treat them like I would anybody that I was meeting. And like, I'm friendly. I ask them, like Ron said, what's going on in their life, what's going on with their day. I don't like make the whole conversation super centered on drugs, and then especially not on treatment. But yeah, just like getting to know a person. It seems like the more a person trusts you, then the more opportunities you're going to have to kind of get in there and offer access to treatment.
Yeah, I agree. So much of this is about like building relationships, you know, focusing on engagement and being like normal, curious, compassionate people, right? Like talk to people about drugs. That's like, you know, I think especially in my setting as a doctor at a hospital, in a hospital-based clinic, like people are, you know, there's been so much trauma in that setting for this population. And I think having a different approach can be really refreshing. And I think sometimes it's hard for folks to take that step, but it's not hard. Like it's easy. We just got to like talk to people and be nice and compassionate, right? And I think there's some reluctance depending on what setting we're at. That's why I love this panel. Like everybody's in different situations here, and you know, I couldn't agree more with what you guys were saying.
You know, it's so interesting because just drug use in general is like stigmatized, and then when people have conversations it's usually punitive. And so having open dialogue, it's like, I just want to know, you know, what's great, what's not great, and like how we can support you. We're not saying anything is bad, we just want to like keep you alive and healthy. So but that's something that folks need to learn, because historically it's always been, oh, you're a drug user, bad, or this is why this is happening to you because you're a drug user, versus just like, how's it going, you know, like having open dialogue. So coming with that approach to folks is like, this is a safe space and we have a network of people who it's a safe space. But historically folks have always been, you know, like hiding that they use drugs because it's stigmatized, and they're going to get the finger wagging at them.
Hey,
I al-
Sophie, time check. Sorry, it's 11:45. I just wanted to.
Yeah, thank you. No, this is
Yep.
great. So I think you guys have shared some really great priorities around building relationship and just engaging people as people, first of all, and then also just opening up a non-judgmental conversation. You know, what feels great for you? What doesn't feel great for you? You know, what works for you? What do you see is working and not working? So that's a great connector to our next part, which is to share some stories. So want to hear from Eric and Kate on two stories. So Eric, first on a story from the emergency department, how you were engaging somebody who wanted to leave.
Yeah, so this was, and I'll try and be brief. This was a patient who was out with his brother. They were partying. It was Saturday night, and he was trying to use cocaine, and turned out there was some opiate in it, probably some fentanyl, and overdosed in the car. His brother drives him to the emergency department, like ambulance bay, and honks the horn. We all run out there, and there's naloxone everywhere. We gave him naloxone and started breathing again. So it was a super, super close call. He really looked awful, and then, you know, did start breathing again and was awake right away. This is not a guy that normally was using opioids, so he didn't feel terrible either. He just woke up and was kind of ready to go, but had been partying like the whole night. So I think a lot of you guys are sort of familiar with this idea, right? That when you give somebody naloxone after an opioid overdose, the naloxone is shorter than the opioid most of the time. Okay, I have to address this. Great. Is naloxone effective against fentanyl or less effective? Sometimes you have to use more naloxone for fentanyl, but it is absolutely 100% effective. So this patient is like, you know, like he had been partying, was ready to go, but the opioids blocked right now. And I'm concerned that he's not using opioids regularly. This is going to like come back again, like 30 minutes. And he really wanted to go, was insistent on wanting to go. And so we had to come up with a plan for him to go home and actually be safe, right? And I said, okay, well, who can you go home with? He's like, well, I came with my brother, but he is having a good time. He is not someone that I should be going home with right now. I'm like, okay, like what's another plan? He's like, well, I have a friend here. He identified somewhere else he could go. And we were going to set a timer on his phone for him to give himself more Narcan, because this is not somebody that was going to have opioid withdrawal symptoms in order to, you know, like feel awful when he takes Narcan. This is just someone we wanted to keep awake and breathing again for a little bit longer. So we came up with this plan for him to like walk to his friend's house. He's like, I'll stay awake. I hear what you're saying. This is how I'm going to stay awake. And walk to my friend's house. It's right down the street. I'll go there. He's not using. My phone timer will go off. I'll give myself Narcan again. Then he can watch me for a little bit longer. So it was a way that we were able to try and like talk about what's going on and build a relationship that enabled him to do what he wanted to do. Like he wanted to be in a hospital anymore. He wanted to have an IV and just sit there and have people stare at him, you know, but be able to come up with some plan that was safe for him to go and get somewhere else. And so I think that we often in hospitals and emergency departments especially are like, no, you can't leave, or fine, you're leaving, you know, be careful, sign this form or whatever. But we have to be able to come up with plans that really like focus on what's going on with people. Like, who are you with? Who's your brother? Where are your friends? How can you use Narcan again if that's like a reasonable thing to do? And actually like jump into some of those details. And he left and was like, thanks. He like gave me a hug, you know, it's like, great, this is a good plan. I feel good about it, you know, and it's just a different situation than it would be if we're not focusing on something that's really patient-centered is going to work for what he's going to be doing for the rest of the night or what he wants to do. So that's my quick story. And
Great. Thank you, Eric. And it's a great example of just like working with what people are doing with their real life and making it work for them. Cool. Thank you. And Kate, you also had a story to share around stigma and supporting coworkers.
Yeah. So this is sort of a sad story. I had a good friend that I lost a few years back who had been working at one of the more well-established, like been around a really long time, harm reduction agencies in the Bay. And I think he felt, he was like a lifelong drug user in his 40s and had a lot of experience with it. He, I think, felt like he had gotten the job he had kind of based on his life experience partially, but the flip side of that was when he started kind of struggling with his drug use and that became known at work, he also felt really judged about it. Like he got in a car accident in the company van or whatever, it's like, oh, because he's on drugs. If he's tearing up in a staff meeting, oh, it's because he's on drugs. So it's like, this is an attribute on one side, but then on the other side, you know, like people are more skeptical, don't trust you as much. And so I think he started keeping it very private after a while. He and I were using together, and then I kind of stabilized on my bup and my buprenorphine, and as far as I know, he was more or less using by himself. And he was found by his life partner from an overdose one afternoon. So I guess kind of the point of the story for me is like, even if somebody's drug use is affecting them at work, which it might, like in reality, how do we hold space for people around that? Like, we don't really care about the company car, do we? You know, is, you know, like if somebody is emotional at work, is that a problem? You know, like how do we make people feel safe to be open about what's going on with them, and so that we can help them create safer ways to use and keep them alive, because he was a huge asset to us and like a really good friend to me, really important person.
Yeah, thank you, Kate, for lifting his story and also sharing that deeply personal story as well. Just a really important reminder for us that this affects us all and it's all around us. And it's so important for us to keep that non-judgmental openness and safe space for people in our lives, no matter where, right? In our workspace, in our professional space, but also in our personal and community spaces too. So thank you so much for lifting that up, Kate. It's really super important. And it's life-saving, really. You know, like once you have that open conversation, that safe space, there's a lot better chance that people can reduce the harm of overdoses. So yeah, thank you. So with that, Bronze, yeah, did you want?
There's a question I really want to address. It's
Yeah.
And if we have time, because I want to respect that, is someone's curious. This is Layla. She's curious about what the panel believes has been the most effective in addressing racial disparities as it relates to our topic. And what I can speak for as far as HEPAC is being a Black-led organization. serving BIPOC community, which is Black, Indigenous, people of color, and you just all the community, but real focus on that is creating access and access points and hubs. So going into the Black and brown communities, working with partner agencies that serve those communities and making sure that they have equitable access. Access looks different for people. A lot of our folks will not leave a 3-block radius. They will, so it's like, okay, what agency I know was in that 3-block radius that we need to equip with Narcan, with training, with access points, because Het Pack and Pumps with Lunch is not always going to be there, right? Like if we were able to be funded to work 24 hours a day, we would, right? But we aren't. So it's like, who do we need to partner with so that folks can go to the liquor store, go to the library, go to the shooting gallery house from the, that person. So whatever that looks like is creating access for folks. And then I heard something about using at work, and Katie, I'm like, so the realization is like, we're in this harm reduction world where it is open that we work with people and hire people who actively use drugs, right? And so it's about checking in with those folks. But there's other folks who may be on this line where that's not even a thing. Like you're getting drug tested to work at a hospital or this, that, and the third. So what I can say for us is just checking in with people. If you're dosing at a certain time and you're on methadone and it's going to cause you to nod at a certain time, hey, maybe you come in late. Having that open dialogue with your staff to say, hey, it's not about your drug use, it's about your behavior at work. If your drug use is impacting the behavior and it's noticeable, then hey, you're nodding out. It might not be good for you to drive the vehicle, or it's like, how, just really checking in with people in an open dialogue. But remember, we're in this world of harm reduction where that's an open dialogue. Some of these folks don't even get that option where they work. It's like, you ain't supposed to be using drugs at work, period. But then that goes into the deeper conversation. What is a drug, whether it's illicit or illicit, or illicit or illicit? Some people have to pop, all kinds of over-the-counter pills to just get up and function, but nobody's questioning them versus somebody who needs to inject or hit the pipe before they get to work. It's like, whatever gets you up in the morning to get you in these doors, hey, that's you. It's about your behavior. So I just really wanted to address that.
Yeah, I totally agree, Bronson. I think we need to make a huge effort to bring drug users out into the light, and like we need to help people feel like they don't need to keep secrets about their drug use, basically.
Yeah, that's great. Thank you so much for addressing that question, that really important question, and also the advocacy around bringing people who use drugs into the light and just normalize things and, make things work for folks. So really appreciate your input and feedback and insight on that. So the next part is for Bronze, for you to help us learn how to use naloxone. For those of us who haven't used it before, how do we recognize overdoses and how do we use naloxone?
Awesome. Let me take off my virtual background so I can get theatrical if I need to be. So hello, everybody. Just to give you a brief update of what Het Pack does, we've been doing overdose prevention, naloxone distribution before it was a funded program. We are Alameda County funded program. Our program is called Opened, right? Because who wants to say overdose prevention, education, naloxone distribution all the time? So we call it Opened. And it was directly funded from Alameda County Public Health about 5 years ago, when nationally we were starting to see an increase in opioid overdoses. Fentanyl was like on the scene, but it's not as big as it was now. And so we had 3 different tiers of what we wanted to do, right? We want to directly train people who are actively using it. We call it like people in the tents, right? And so we go to folks encampments, we train them on the spot on how to use intramuscular and nasal Narcan to reverse an overdose, right? So that's direct one-to-one. Then we have what we call train the trainer. So this is training agencies that would be considered first responders and agencies that see people who are substance users. So if someone, let's say, falls out in their lobby or one of their staff is experiencing an overdose, that they can respond directly. And then we also train people to be distributors. And so we call these people partners. So that means, okay, you liquor store, you library want to be able to distribute this product to anybody who walks through your doors and asks about it. We're going to train you on how to do that. But even though this is free, they say really nothing in life is really free, right? Because I need data. We're going to give you 20 kits. At the end of the month, I need to know how many people took the kits, right? How many overdose and reversals did you have? Like, I need information to know this is actually working. So when we're training people, we're thinking about the setting that we're in. If we're working with people who are like, hey, I'm on a time frame, I'm in this syringe exchange line, I want to get my stuff and I need to go. Like, I can't sit here for 30 minutes and talk about opioid overdose. Like, give me it quick and dirty. So it's like first assessing where you're at and who you're talking to, because sometimes some of our participants ain't got all the time in the world. So it's like, okay, I need to give this person very concise information in a 5-minute span, you know, so that they are aware on the basics of, one, identifying opioid overdose signs and also responding to opioid overdose signs. So is this form anywhere, Sophie? Are you able to?
Yes, so that's in the handouts, and if you want, I can share screen if you want me to pull it up.
Let's share some screen if you can. If not, I'll talk through it because I have
Yeah,
it
just
here.
give me a few moments.
Okay, cool. I'm gonna keep running my mouth while Sophie's pulling that up. So one is identifying the signs of an opioid overdose. One is, these are some typical signs, and Kate, please jump in, or Eric, if you know, because I'm on a panel of just experts here. We all do this. Blue lips, someone's if they're having an overdose, blue lips, blue nails, they're breathing slow or absent. It's interesting, when I first started learning about this, is the pupils. When people are off of uppers or amphetamines, usually their pupils are really, really big, right? And then when folks are off opioids, they have what they call pin-sized pupils. Choking, gargling sound, dizziness or confusion, and cold, clammy skin. And then obviously non-responsiveness, right? So if somebody is like unresponsive and you're like, hey, what's going on? And they're just, one, having all these signs you're seeing here, but they're just non-responsive, that could be a clear indication that someone is overdosing. And so sometimes folks, you know, you're like, hey, did you use any opiates? They don't hear you. They're not in their, you know, space to even answer questions. You got to like know these signs. And then just, it's like, okay, I'm seeing the signs. Now it's time to take the steps. So one is just obnoxiously yelling, hey, are you okay? Doing the chest rake, right? The really uncomfortable, like if I'm having an opioid overdose and you're doing something very uncomfortable for me, if I come out of it, maybe you're not having an opioid overdose. Maybe I was just a little, you know, my drug was just not, I wasn't feeling it right. But if you're doing all this uncomfortable yelling and raking of the chest and a person is not coming out of it, that's like a clear indication. Then another thing is, you want to say, hey, I'm about to administer Narcan, right? And that's kind of letting them know, hey, I've got to the point, I've raked your chest, I've screamed and hollered at you, you're non-responsive, I am giving you the final out, I'm about to administer Narcan, like, give it to me now or we got to move forward, right? And then it's delegating. So if you're there by yourself and you see somebody overdosing, it's hard to say, hey, you call 911 or you do this or you do that. You might just have to be like, Siri, call 911. Hopefully if you have an iPhone and a Siri, right? But making sure that you contact some authorities, because you may not be an expert, right? And even if you are, you're going to need medical attention to hopefully support this person if they come out of this overdose due to you administering naloxone. So then step 4 is perform rescue breathing. Now, there's some folks who are like, hey, we would prefer to do rescue breathing versus chest compressions. And in the moment when you're saving somebody's life, keeping their breath alive, for me, would probably be the best. But some folks argue that keeping their heart pumping is the best. And so I would love to hear from Katie and Eric on what their preferred method would be as we're going through this. And then also it's administering the Narcan. And so we have different kind of Narcan. When I first started getting into this, nasal Narcan was not as popular as it is now or widely available. This is very easy to use. It's very digestible for people to say, hey, this is like an atomizer or an inhaler or like that thing you put up when you've got allergies. This feels comfortable for me to use versus, oh my gosh, someone's overdosing. I need to draw up, I need to unpack the syringe. I need to like draw up a vial and then I need to like hit them in a muscle. So just imagine someone's going through it, someone's overdosing, you're already traumatized with this whole situation. Then having to use this can be even more stressful. But when you're talking about saving someone's life, hopefully we're just like, hey, adrenaline's going to kick in. I remember what the training from the bridge or Pumps with Lunch or Het Pack is just like, do your best, right? Our main goal is to keep this person alive and get it in their body so it can reverse an overdose. So on these pamphlets that we give out, it gives you one, the signs of opioid overdose and puts it in a picture form. And we like this because specifically for our participants, if I just have a sheet with a whole bunch of words on it, people in our experience don't want to see all that. I'm a visual learner, and I'll speak for myself. I hear from a lot of our participants that they're visual learners. They want to see like step 1, 2, 3, 4, boom, let's go. So having anything that is visual, easy to like see, these are the signs, makes it easier for you to absorb the information. And so please steal this, take it, put your logo on it, use it. If it works for you and your agency, it is not exclusive to Het Pack or Punks with Lunch or any of that. Just please use that.
It's also in Spanish. So in your handout, the last 4 pages of your PDF are these 2 flyers.
Yes. But right now, what we're hearing from participants, which are the field experts in this, as this is a lot easier to, 1, carry on you, 2, administer, and then 3, it isn't as stressful. But I do want to say there is conversations around which one's efficacy is more. Well, there's a time where if you put this in someone's nostril and it's not like taking effect, you're going to have to do another one. There's conversations around that this is actually stronger than the nasal. So what we like to do when we give out our kits is you have an option of both. You can get this, which has Narcan, the intramuscular, as well as the nasal. It also has the Good Samaritan law, because a lot of times people would leave the scene because they feel like, oh shit, I'm on parole, or I've got drugs on me and the police show up. I'm just trying to save this person. And then now I get arrested, right? There's Good Samaritan laws, but Het Pack and all of our agencies can't say that you're not going to have some kind of drama as 100%, right? Because I'm not the police. I don't know what they will and will not do despite this Good Samaritan law. So it's always just good to make your participants aware, right? But we give them information about the Good Samaritan law. We give them information about, all the places to basically inject them. If anybody's seen, I think it's Pulp Fiction, correct me if I'm wrong. There used to be like this old thing where they would like, you got to stab them in the heart. Do not stab anybody in the heart with Narcan. Please don't do that. All right. Not even with an EpiPen. Right. And so we want to make sure that it is happening in the areas that it's supposed to, which is the fatty parts, right? Your arm, your buttocks, the front, like the meaty parts of you. Just lost a train of thought. Oh, okay, yeah. So when you come to Het Pack, you get an option, right? You can get this cool little bag that has intramuscular as well as the nasal. But then we were starting to hear people say, well, shoot, I just got so much stuff. I got bags. This bag's cute. I use it for this and that now, but like I need something pocket size, right? And so we came up with these keychains because most likely people are going to carry their keys with them. So anything that allows it to make it easier for you to carry Narcan on you, Het Pack has little keychains that you can keep on you so that you have it, because it's only going to work if you have it on you. And so we did this whole study to be like, why are you not carrying Narcan on you, right? Us being the providers, like, it's simple, but that's us thinking in our brain. When we had to really hear from our field experts, what is the barrier to you carrying Narcan on you? And people were like, I got a lot of stuff. So it's just like, whatever we got to do so it is the most comfortable for you to carry Narcan on you. I'm like, let's make a keychain. Let's do this. Like, we're giving out free backpacks with it in there so that you can, 1, get supplies at the exchange. Everybody loves a backpack and swag, right? But like anything you need to do to keep Narcan on you, we support. And having this open dialogue, because all these fun Chotsky stuff might not work for everybody. So it's really talking with people about like, what's the risk factor? What have you seen? And what are some reasons why or why not you might have had Narcan on you? But what I can say is since we started doing stuff like that, we have seen numbers increase. And what we do is we kind of check in with folks. So we'll be at the syringe exchange and say, so, hey, you got your Narcan on you? we'll recognize somebody who either got a training or whatever, and they'll be like, yeah, I'm like, okay, well, show it to me. And when they show it to us, we'll give them like extra snacks and stuff like that and have the open dialogue. So that's kind of like the training in a nutshell. Now, when you want to be a partner, it's a longer training, right? We got to sit down with you and your staff and talk about like the data and the paperwork and what it means to be a partner. And then when we're doing train the trainer, we got to sit down with you and it's a little bit more in depth. But for the people who are actively using drugs, we've noticed like folks ain't got a lot of time. So it's like concise, brief. This is how you identify it. This is how you bring people out of it. And then we like people to model. I'm very theatrical. A lot of our staff is theatrical. We're like, someone's ODing. What you gonna do? Let's see it. Either talk it out or walk it out, what we like to say. And we give incentives for this. We always have little extra stuff we can offer people and make it like inclusive, make it fun. That's how people like to learn. Visual and fun and entertaining kind of makes these sad, somber situations more digestible and easy for people to learn. So that's my spiel and my training and how we kind of do things at HEPPAC. So yeah, now I'm off my soapbox. Does anybody have any questions, or other panelists, do you have anything you want to add to that? Because y'all are experts in this too.
Can I jump in, Bronze?
Definitely, please.
Just a couple tips that I've learned in my life. One is when we're trying to determine if somebody's actually overdosing or they're just in a heavy nod, along with, like rubbing on their chest and whatever, telling them that you're going to Narcan them. If they are at all awake, they'll definitely ask you not to, because it brings people into like a severe state of withdrawal. And people that use drugs and have been Narcan know that. So there's like a deep-seated fear of being Narcaned. So they will definitely let you know. That's worked really well for me. Also, I remind people that like in the shit scenario where they don't have any Narcan, you can keep somebody alive until an ambulance gets there by breathing for them, right? So like the rescue breathing is really so critical to make sure people know about that part. And I had always been trained like not to do anything with a person's heart, because you can actually stop it by doing by pushing on somebody's chest in that way. I think that's all I wanted to add, Bronze. I think that's it.
I want to,
two quick questions, and then we should move on to Kate's drug log, if that's okay. Quick question: how do people get more training? How do we contact you for Narcan kits?
Well, we just hired a brand new overdose prevention education, naloxone distribution open coordinator. Her name is Brooke, and you can contact Brooke. We can provide you with the email at the bottom, and just, it's based on requests. Everybody needs something a little bit different. So if you're like, hey, we want to be a partner, or oh, please come join our agency, or I just need 2 or 3 doses, you can easily contact HEPPAC and we will give you what we got and kind of assess the situation.
Great, thank you. And Kate's answering some questions in the chat as well. If somebody's not actually on opioids, the Narcan doesn't do anything. And then also, I think Brooke has put their email in there, which is great. And then I also put in a link to other locations that do naloxone distribution as well as needle exchange. So all of those things are in the toolkit that we'll share with you shortly as well. So Kate, can we go to your drug log and you can show us? Okay, great. So what we want to share with you is basically what inspired our safety plan. And it was basically when we were talking about harm reduction, Kate was talking about drug journals and how important it is to know what you're using, your dosing, your schedule. So Kate, do you want to describe this more?
Yeah, so this is actually a drug journal of mine. And as we kind of look through it, there's actually, so it's helpful to literally keep track of the different drugs that you're mixing, because it's very easy to forget. Just like, I know people have used this when they're dieting or trying to change, their eating habits or something, like keeping a journal of what they eat as well, because we all know that things just go in our body, right? Sometimes we're just absent-mindedly ingesting things, and the same is true for drugs. So yeah, keeping a good record of that. But also for me, this was an exercise in getting to know myself better, and how the drugs I take affect me. like physically and emotionally, and how coming off of the drugs that I take or I'm dependent on affect me physically and emotionally. So like during this period that this journal was being kept, I was transitioning onto bupe from just being steady on street opiates. It's noted here that like sometimes I might refer to something as heroin. It's not really heroin anymore. If you're lucky, there could be a bit of heroin in the tar that you buy here in the Bay Area, but it's entirely possible that there's actually no heroin in it. It's like a fentanyl substance with other shit, depending on where you get it. So I'm calling it tar just because I don't really know what to call it accurately. And so, okay, so this like first day, we're starting off with 8 milligrams of bupe, and I'm still using heroin with it. So this is like, I think Eric might talk a little bit more about this later, or I don't know, but we've had sort of a new style of induction with buprenorphine than the old way we used to do it, where we would ask people to wait like 24 hours and be in severe withdrawal before they start the bupe. There's like a slow induction method that we use these days, if people want to, where you can kind of juggle them both back and forth and like slowly introduce the buprenorphine into your body while you're still using heroin or fentanyl or whatever. But you have to kind of be careful with the amounts, because if you get too much bupe in there too early on, then you could still have like a withdrawal effect that's very uncomfortable. Which is actually like the bupe is stronger on your receptors, so it kicks all the illicit opiates off, or opioids off. Okay, so this day I'm taking bupe, I'm taking heroin, I'm taking a Klonopin, which I'm using to like deal with anxiety, which is pretty severe when you start changing your use around opiates. Like your anxiety is often lifted or amplified. Then I'm taking more buprenorphine in the afternoon and more Klonopin. You can turn the page, Sophie, if you want. Okay, so here we're noting like what my night was like. I slept through the night, didn't have much withdrawal, taking bupe again. I don't normally use speed, but I was using speed during this time because I also don't normally take benzos. And so I was feeling like really tired during the day and out of it. And so I was using the speed to kind of counteract that. Marijuana, I feel like, is extremely helpful in these transitional periods, and also just for people trying to taper off. I mean, as long as a person can tolerate, and some people don't tolerate marijuana well, but if somebody does, it's super useful. Speed, I mean, like, I don't know, in this case for me it was helpful, and it didn't like send me off the rails or anything like that. Ideally, I would love if we had like Adderall or Ritalin or something to deal with, just so we know what it is, because speed's another substance that's just got it's very strong, like the illicit stuff, and these days, and we don't necessarily know what's in it. Could have randomly fentanyl in it or something, which is concerning. So let's see. I'm talking about why I'm taking different things in here. Like, so there's 2 sips of Fernet, which I guess I'm using to potentiate my Klonopin, right? Make it stronger. This is like I'm getting towards sleep time. Randomly, I had gotten a stash of Quaaludes, which don't even really exist anymore. But so I was experimenting. I had never taken Quaaludes in my life, but I was experimenting with them as a sleep aid, which they were great for. And I didn't have any negative consequences from them. The mushroom tea is, I use it for like serotonin, which is pretty depleted during withdrawal or like switching over to bupe. So it can help with your mood stability. And then it's noted here like what my withdrawal symptoms are. It's mainly temperature stuff, body temperature stuff, skin stuff. What I mean by that is like goosebumps, or just like a general sort of sensitivity to your skin that's really uncomfortable. Very emotional, crying a lot. That's like also important to have for me anyways, like writing down the emotional side effects of things, because sometimes when I get deep in it, I'm like, it's hard to stand back and recognize, like, or remind myself, like, okay, this is something that is physically going on in my body, right? And like my brain's reacting to that. I'm not really this depressed, and this will come to an end. Like, this is just a part of what I'm going through. And it's drug induced, like it isn't my constant state. So you can turn the page again, Sophie. Oh yeah, and look, I'm even talking about what I'm eating, which probably isn't much. I always really struggle to eat during these periods. So it's good that I'm noting, like, I'm trying to get some food in me. I'm sure I ate something besides a smoothie in 3 days, but like, it's cute that I put that in it. You can flip it again. I want to get to the page where I'm talking about, okay, well, so here's some, like, there's a couple things I want to talk about here. I don't know if people know what a cotton rinse is. That's like, this is pretty gross, but it's basically like the residue left in a cotton after you used a cotton to filter like a previous shot. So this is terrible drug etiquette. Like, nobody should ever, it's really, really, it's full of bacteria actually, because it is literally the filter that you used, but this is just honest. So that's actually been a thing for me throughout my drug using career. Like, when I am trying to taper off, that'll be kind of the last little bit of drugs that I let go of. It's like not even a measurable amount, and it often seems just psychological for me. And like, it's basically like using water. That's just got a tiny bit of brown tint to it, but sometimes the psychological part is important. And the ritual is definitely important, and that's a really hard part to let go of. So that can be noted. I am also noticing here where I start talking about felt the heat flush, that it seemed like I could almost notice in my body that when the drugs came up against the bupe, that was kind of the main side effect I was feeling, was like this heat flush that would happen in my whole body very briefly, and then it would go away. Besides that, I wasn't really having any interaction issues.
Kate, we have about 10 minutes left altogether. Is it okay if we transition to the safety plan case?
Sure, of course.
Is that cool? I really appreciate you sharing this. Like, this is just so amazing to see what a drug log looks like in real life, and just so great to see how you were able to keep track of things and how you were feeling and what you were eating and all that stuff. So this is a really perfect example for how we can help people keep track of what they're using and to support them through that.
Yeah, totally.
Yeah. Anything else you want to say about this before we go to the safety plan? And just thank you so much for your willingness to share this.
Yeah, no problem. Sorry I took up so much time with this.
No.
No, like, I guess there's, if you all got these slides actually and you feel like reading them later, there's more sort of notes about like interactions, like the stuff that using the different drugs kind of brought up for me. Like this whole thing about the episode I had with the speed, where I redid my alter and had a long talk with myself. It's like these drugs that we automatically often assume are just negative and like don't have any positive use in our lives. They definitely can. And so I just think it's important to note like all the things people get out of their drug use. And that's where I guess I'm going to end it.
Yeah, great. Yeah, no, and this is totally, it goes back to also what we were talking about earlier, you know, what's great about it, what's hard about it, right? So it's all those things, and it's good to be able to talk about all of it. So with that, I want to say that Kate's drug log was the inspiration for developing this toolkit. As we were putting together the safety plan template to basically help people do what Kate did, we realized we had so many great resources, including that naloxone overdose prevention flyer that Bron shared with us in Spanish and English. So these in your handout are links. Just want to show you what you download is this document. And all of these links go to the template, a directory for getting naloxone, the PDFs that from HEPAC that Bron shared on how to use naloxone. Punks with Lunch and a bunch of collaborators have this live document that gets updated on needle exchange locations, which also provide naloxone. We have links to the Bridge team, substance use navigators, to get people into treatment. Also, their primary care providers can sometimes do that. And then more services here. So those are all the links which you get with this toolkit. And we were going to really focus on this comprehensive safety plan. And then there's a short 3-question safety plan that you can do. So we wanted to provide you a short version and the long version. And using this example case, if Eric, you want to read this case real quick, and then we'll focus on some of the high priority safety plan items.
Yeah, sure. So this is a case of, this is Mike, 34-year-old cis man, injecting meth and heroin. He lives by himself in a tent. He also drinks alcohol most days and sort of treating his anxiety. He prefers to live by himself, and he doesn't generally use his tent, has sort of like a lot of social anxiety and does like to use alone. He's on and off bupe for 2 years. Just will kind of alternate back and forth, maybe a day or two on bupe, and then using heroin again, and then back on bupe. And he does this because he still wants to be able to use sometimes. And so I think we'll talk next about a safety plan for him.
Yeah, so somebody injecting meth, injecting heroin, drinks alcohol, on buprenorphine, lives alone in a tent. Yes, right? So these are like the big salient points here. So how would we help Mike make a schedule? So you can see in the drug log example, there was a schedule here of what was being used. And in this case, a schedule would keep the supply and the use safer for Mike. So how would Mike potentially answer this question? How many times a day do you use? And how consistent, financially sustainable is it? So I think what you're just trying to do is coach Mike or help Mike figure out a schedule so that he has a wake up dose, right, Kate? And then also know that he has the money to pay for what he needs to avoid a withdrawal or to avoid needing to go out and find something that may be less safe than
exactly. Like it seems like the more consistent your doses are, the less likely you are to get yourself into a sketchy situation where you're doing desperate things. Like desperate measures put us in desperate situations.
Exactly. So you're helping Mike just be on a safer use schedule.
You know, one other thing I can jump in is we talked about patients doing this a lot with when can you take your bupe in between using and things like that. And Kate had some awesome examples in the journal. But this is someone I also might talk to about, like, you know, you can take a full dose of bupe on the days where you don't want to use, but it also can be helpful to take a really small amount of bupe on those days where you might be using to some like protective effect. And then you don't have a whole lot of difficulty, if at all, really transitioning back to bupe the next day.
Yeah, that's a great point. So when somebody actually does have a drug log, then you can look at it and help them figure out how to jigsaw things together so that it works for them, right? Exactly what Kate was doing in her drug log, but also Eric, as you as a provider, to help coach them through, okay, this is where bupe might work for you better, or, you know, help them think through that. Bronze, you had your hand up too?
Yeah, just really quick. I always want to plug the fact that all these agencies here have other resources that can help financially. You know, if we have a food pantry and you're getting food, that's less money you have to spend on food that could support your medicine that you need. So it's like knowing your resources to be like, hey, okay, we're talking about the financial economics around drug use and what that looks like for you. It's just like, go to HeadPack, go to Posters Lunch. They can hook you up with lunch. They can hook you up with a food thing. They can hook you up with things that are gonna help your pockets, basically. So I just always want to plug the ancillary services around economics as it relates to people's substance use.
That's right. Great. Yes. And that's a really important aspect of harm reduction too, is supporting the other aspects of their lives as well, so that they can remain stable and safer. Great point. Thank you. The other thing about Mike is that he uses alone mostly. So how would you coach Mike around using with somebody? And what if that person isn't around? How would what if you asked him this? He's like, I just use alone. I don't really use with anybody. How would you coach him around that or talk to him about it?
We had talked about that, like, where you get your drugs is often like if you get your drugs from a camp, say, where like there's a lot of people around that are all sort of using, that you can kind of use by yourself, but around people in a place like that. And that you're likely to have plenty of other drug users around you that would notice if you went out.
I know, Katie, me and you had kind of talked about this, is if someone's using alone and having the conversation about like, what are going to be your signs if you feel like you're slipping into an overdose, and how are you going to be prepared, whether it's having nasal next to you, nasal Narcan next to you while you're using your drugs, because I'm sure it's going to be a lot harder to unravel a needle and do intermuscular and draw up if you're like going out versus like, oh, I feel like I'm falling out. Let me get my, kind of situation. So really having that open dialogue with folks on like, what does that look like for you if you're using alone and you start feeling the signs of overdose? And it's going to be different for everybody, but just kind of like they're the field expert. What does that look like for you? And kind of talk it through, because I can say, yeah, just have your Narcan on you right there. And when you're about to fall out, just nasal yourself. It's not going to be that damn easy, right? So like just having the dialogue, like, what's the plan? Did you tell somebody to have a check? Like, hey, I'm about to go in my tent, check on me in like 5 minutes or whatever, or shout out to me or something, So have that open dialogue with our participants.
Perfect. And I'll add that to the safety plan toolkit too. I like that. What does it look like for you, right? When you feel yourself slipping into an overdose. Great.
Can I say one thing real quick?
Yeah.
Sorry. We had also talked about in that conversation, there's a lot of problems with skin popping and intermuscular injection in terms of infections and stuff. But if you were going to just do it like on, say you had a long period of sobriety and this is your first time using after a long time, I think that the benefits of using in that way on that occasion outweigh the chance of infection to me personally, and that it hits you slower when you skin pop or intermuscularly inject. So you would potentially have more time to Narcan yourself if you really are alone.
Yeah, great. So this is perfect because it goes into this section of the safety plan is with tolerance changes, right? So if you haven't used in a while, your body can't handle the same amounts as before. So these are different strategies that people can use, and it's good for them to know and have them ready to use, right? If they're willing to stop using needles, as Kate was mentioning, skin popping, booty bumping, right? Other methods, snorting, are slower. And so you have more time to reverse or to slow down. And then starting low, going slow, and avoiding mixing. So what would you advise them around avoiding mixing?
Benzos and opiates.
That's a big thing, right? It's like mixing your opioid with benzos and probably alcohol, but really we just like benzos and opioids is a really thing that counsel people about for sure.
Yeah, thank you. So those are, I think, the most important aspects of the safety plan. And then more of the safety plan is around like buying from people you trust, where you get other harm reduction materials like sterile needles and syringes, condoms, PEP and PrEP for HIV prevention. Counseling people on what staying healthy means, names and contacts of people who can help. And then the drug journal, like keeping a drug journal, just as Kate had shown before. So with that, I'm going to stop there. We had other cases to talk about, so maybe another time we can talk about that. But I think you got the biggest 3 questions here. Who can I use with? How can I reduce my risk of overdose? And then talk to them about who can check on them. So we are at 12:30. Thank you so much for joining us. Just really big thanks to our panelists. Thank you to Kate. Thank you to Bronze. Thank you to Eric. Just really appreciate you sharing your experiences and your expertise with the whole group. Thank you to all of you for joining us and talking about this really important topic. Please share your questions and any remaining thoughts you want to share with the group in the chat. We'll try to get back to you if we haven't answered it here. Please complete the evaluation for us. That helps us understand what works and doesn't work for you. Try writing a safety plan for somebody and help somebody do that. And we'll have all the updates, any feedback you have for the toolkit, and then any resources you want us to add to it, please share it with us in chat or email me. We'll continue to update it and keep it live for you and keep it current. And then finally, please join us in October for our Housing 101 workshop. Housing and substance use often go hand in hand, so hope you can join us there. One last poll. I don't know, Jessica, do we want to share this real quick? Just, we wanted to find out from you if you wanted to try to meet in person or via Zoom. So if you guys have a preference there, we can look into it for October. And of course, will depend on how the pandemic's going too. So yeah. So really appreciate you all. Thank you so much. Big shout out to all the panelists. Thank you so much to all of you. Really appreciate you and look forward to continuing to work with you.